welcome to day 2 of ARM. I hope you've already had a chance to go to maybe a morning networking session and at least one breakout session, though I kind of hopped around and caught a bunch of different topics, which were fascinating. I also hope that you've had a chance to visit our many exhibitors and, importantly, check out the interesting posters and give comments back to those presenters. Now we turn to our plenary session. This plenary asks the question, are we making progress on equity? An important question, what progress are we making? And as you heard me say yesterday in my opening remarks, this is a topic that Academy Health has made a priority, and you will see equity as a theme throughout many plenaries and the breakout sessions. If you missed my opening remarks, I encourage you to review them. They are now posted on the Academy Health blog. So it is now my pleasure to introduce the session moderator, Ceci Connolly, the president and CEO of the Alliance of Community Health Plans, who has a stellar panel of discussants to try to answer this question. Ceci, over to you.
Lisa, thank you so much. I want to say thank you to the entire team at Academy Health and your members for, once again, this terrific ARM gathering. It's nice to be back, at least virtually, and can't wait to see everyone again in person. But I just want to say I'm so privileged to be a part of this conversation today, and so impressed that Academy Health now has made this such an important element to the conference. And I know the work that you've been doing throughout the year. And as Lisa said, we have got a stellar group of panelists for this conversation. We want to jump in and make it a good dialogue, and we want to include all of you. So I think at this point, most of us know how to send in those questions on Zoom, and they're going to be shot over to me periodically so that we can include all of you in this conversation, share thoughts, questions, you name it. With that, I would like to just give very quick introductions of our 3 panelists. I won't do justice to all of their experience and resumes, but just to give you a sense of really the diversity on this panel and the way in which we are going to be able to look at this question through so many different lenses here in our conversation. And so first, I'd like to introduce Dr. Nathan Chomilo. Hope I got that right. He is the medical director of Minnesota's Medicaid and Minnesota Care programs. He is a practicing pediatrician at Park Nicollet, which I'm happy to say Health Partners is in our ACHP member family. And he has also been serving as Minnesota's COVID Equity Director. And I can't wait, Nathan, to really get into a little bit of the state experience and learnings throughout this pandemic. So Nathan, welcome to you. I'll go next. Dr. Lisa Cooper. She is a professor of health equity at Johns Hopkins University School of Medicine, Nursing, and Public Health. She founded and directs the Hopkins Center for Health Equity and has a brand new book, terrific title here, folks, Why Are Health Disparities Everyone's Problem? And I can't wait, Lisa, for you to tell us why. And finally, Joy Lewis is a Senior Vice President of Health Equity Strategies for the American Hospital Association, AHA. She is also Executive Director of the Institute for Diversity and Health Equity there. And I would mention again, a nice ACHP connection. She was a senior health policy leader at the Kaiser Permanente Institute for Health Policy. And so we can also, I think, learn from her some of the interesting policy ideas and strategies that can be brought to bear on this important topic. So with that, welcome panelists. Hello, give a wave. All right, terrific. And I'm going to just jump in with a little bit of a framing question because I want to give each of our panelists maybe just 2 to 3 minutes, kind of set the table for us, if you will. I'm going to start with Joy and just pose the question of where are we in this journey, Joy? How's it going so far?
Great. Thanks so much, Ceci, and really grateful to Academy Health for the opportunity to be here today and to be with these stellar panelists and really to have a robust discussion about health equity, a topic that's near and dear to my heart. So I would say overall, are we making progress? Yes, but here comes the color commentary, right? Because if I look back to the days of medical enslavement, the conversation, the context that Harriet Washington writes about in her book, Medical Apartheid, yes, we've made progress from those days. But I would posit that many of the beliefs and the attitudes that existed back then that granted permission, if you will, for Black people and other people of color to be treated less than, that some of those attitudes and perspectives still persist today. And so in our current context, we're still faced with the historical vestiges. And while I would say, yes, we're making progress, it's not to the degree or the speed that's necessary to meet the moment that we're in. And I'll take us even further back to a quote I was reminded of recently. A colleague and I were having a conversation, and she was talking about W.E.B. Du Bois's book, The Philadelphia Negro, and one chapter in particular where he described the health of Black people in Philadelphia in the late 1890s. I will quote, he said, "One of the most difficult social problems in the matter of Negro health is the peculiar attitude of the nation towards the well-being of the race." And then he went on to say, "There have been few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference." And so for me, some of these questions, these big questions, still linger today. They still need to be answered. And I know deep down that this work is the long game. It is generational work, but there's a sense of urgency that I would say many of us in this space feel right now. And when I look at, fast forward to today, a recent study that came out of UCLA in April of this year, where they found that the proportion of physicians who are Black in the US has increased only 4% over the past 120 years. And that in that same study, the share of doctors who are Black men remains unchanged since 1940. So again, these examples really just highlight that progress is slow. You know, there's still a long road ahead on this journey to achieve health equity. And granted, last summer, on the heels of the events we witnessed and a renewed call for social justice, if you will, really required us to think deeper about ways that we can advance actions and strategies to encourage our members at the American Hospital Association to really be innovative in this space. And so I would say there is a window of opportunity for us to have awkward and difficult conversations, necessary conversations. But the goal here is really to leverage this moment so that we can achieve transformative and sustained change in our communities.
Wonderful, thank you. And you've put so many important pieces of this puzzle out on the table for us to come back to. Let me, though, give Nathan an opportunity to help us set the table for this conversation a little bit. How would you describe where we are on this whole effort?
Yeah, thank you, Ceci. And I really want to just build on what Joy set up there for us, and that what I see is that, you know, we are starting to get more comfortable with some of the language, but we are still lacking the action around building, you know, equity. And then I would push us further to look beyond equity and look specifically, as Joy's pointing to racial equity, because there really is no equity if we don't address structural racism and racial equity head on. And so I look at, you know, reports of disparities in health that are, you know, if you look in Minnesota, there's reports of health disparities along lines of race in the 90s that have not changed significantly here in the 2020s. And we've continued to kind of talk about disparities. And it's only till relatively recently that that has shifted to, let's look at the underlying actual structural determinants or social determinants or social drivers of those disparities, instead of just kind of admiring that they're there or thinking that there's some type of behavioral issue that you could attribute to race instead of it being structural racism. And in fact, Dr. Rhea Boyd and colleagues have done several great pieces in Health Affairs recently looking at publications and how they don't often weren't even talking about racism or being allowed to use the word racism within them. And so that is a change that I think is notable and encouraging. But then where is the action that comes with it? And so I talk about building racial equity along the continuum that impacts policymaking. As a policymaker, I'm influenced by what research says. And so let's take a look at what our research standards are. Let's look at how the NIH puts out calls for awards, and is there any use of any of the racial equity tools and assessments to see how research is going to be impacting different communities and the outcomes differently? Is there any acknowledgement of the researchers themselves and the wanting to have a diverse set of researchers that's driving that work? And as one of the largest funders of research, I think that's imperative that we start looking at things like how the NIH puts out grants and how they evaluate them, because then that research then leads to the policies we see. And as a policymaker, I rely on things like data that is standardized to get an inference on impacts. And so what is our racial, ethnicity, language, data practices and standardizations? And we still are really in a space where we need to do a lot of work to better standardize that so that we come to the right conclusions about both the research and about the policies we're looking at and the impact of that on our communities. And then how are our policies really led by the communities that are impacted, right? And if we're really truly striving for racial equity, we really need to have a community lens and not a strictly academic lens. And so how do we bring community better into the process of answering and asking those questions of what the needs are? How do we have communities better define outcomes and successes? And so we hear lots about return on investment and what are the actual benefits of any of these policies and structures, but where's the community's input on what that return is and what that investment is? And so there's, I think, a lot of steps and places we need to go to really achieve equity. Encouraged by some of the steps we've seen in the last couple of years, but I think we still have quite a ways to go.
Understood. And like your point about even as we may be making progress on the dialogue, the difficult, awkward conversations, it's really getting to more of that action step, and also the linkage between research and policy making, near and dear to AcademyHealth and ARM for sure. With that, let me turn to Lisa for some opening thoughts.
Sure. So I agree with both Joy and Nathan that there are reasons to be optimistic and also reasons to be concerned. So, I couldn't agree more that we should have made more progress on health equity by now. We've known for decades and decades that we have inequities in health along racial and socioeconomic lines in our country. It's disturbing that in the last decade of the 20th century, the excess deaths among African Americans was about the same as it was in the first decade of the 20th century. So, that just shows you that despite knowing about these issues, the progress has been really slow. We're still dealing with disparities in infant mortality, in maternal mortality, in morbidity and mortality from cardiovascular disease and obesity and diabetes, HIV. So our disparities are still there. They're still pervasive across conditions, across populations, across settings. And we've documented them very well. It is encouraging that people now know more about what health disparities are. It's unfortunate that it took the COVID-19 pandemic to shine a bright light on health disparities. But now I think more people know what it is. More people have become comfortable with the fact that racism and other structural factors actually shape opportunities for people in disadvantaged communities and lead to these inequities in health. So I think that it's excellent that we've made that progress. And the other thing I would say is that I agree about this translation of research into practice. We have a lot of evidence too about things that work. We know that, for example, early childhood development programs and anything that focuses on children will lead to better health. Reducing childhood poverty, we know, improves health equity. We know that raising income for adults reduces health inequities. We know that improving community neighborhoods, we know opportunities to eat healthy food and to live in communities that are not plagued by climate change problems and environmental toxins will improve health. We also know about what to do in terms of providing access to care. So we have a lot of evidence for what works. And as both Nathan and Joy have alluded to, we haven't translated those efforts into action, in large part because we are in need of building better partnerships between academia and community. We're in need of developing a stronger political will, getting our society to support political efforts and policies that will promote equity, really seeing the connection between who they vote for and what happens in terms of equity. And really, in terms of everyone seeing why health disparities are everyone's problem, like you mentioned, the title of my book, the fact that inequities don't only harm the communities that are affected by them directly, but harm us all through their negative impacts on our mental health, on social conflicts, as we saw last year with, the Black Lives Matter movement in response to the overwhelming violence perpetrated against people of color. So health inequities are bad for all of us. And health equity is actually not a zero-sum game. It's a situation in which we raise the people who are most affected, but it actually ends up helping other people as well. So hopefully that's the direction we're moving in. But like I said, I'm cautiously optimistic only because I've seen that progress is so slow. And also I know that attention shifts. So like right now, it's the issue of the moment, but we have to really seize upon this and leverage this focus and make sure that it doesn't get forgotten in the next year or two.
And I think Lisa is sort of headed where I was hoping to go with this follow-up question for everyone. It may seem to you three, because you've devoted your time and energy to this topic, it may seem obvious to three of you, but for our audience, maybe just talk a little bit about where health disparities and addressing those gaps in healthcare and the health system and health outcomes, how does that fit into the much bigger discussion and effort underway in our country right now over racial injustice, whether it's looking at criminal justice system, policing, looking at economic factors that Lisa referenced a moment ago, or policies, business practices, workforce and hiring. I heard a mention about Black physicians, and that makes me wonder about medical schools. Nathan, maybe you could start with just where does the healthcare effort focus into the broader?
Yeah, I think that gets to how health is really not just doesn't just happen in a clinic or a hospital. It is really related to those opportunities that Lisa was talking about. And so your health is related to where you were born and what type of housing situation you came home to, what was the prenatal health and status of your parents and family, what was the air you were breathing, the water you were drinking growing up, what type of food, nutrition did you have access to, did you have access to early childhood programs that helped stimulate your brain growth, did your education system support you, did you feel safe in your neighborhood, were you able to have what you needed to, graduate and go to college and get a successful job, get access to a home loan yourself. There's so many different ways that health is tied to things outside of healthcare, and that's really what the kind of social determinants or social drivers of health get at, and that is what leads to disparities in outcomes. It's not solely upon the individual choices that folks have. It really is about the opportunities that they do or don't have that really impacts their health. And so many of these gaps start early, as Lisa talked about, in those first 5 years in particular, we start to see many gaps appear. And so, and then I think there's connections throughout. And so even if you think about an individual's engagement with a healthcare institution that isn't aware of its own structural racism or biases, that if they have a poor interaction, that's going to impact their ability and interest to interact with the healthcare system elsewhere. Or if there's an overlap between interaction with law enforcement, and that leads to them interact their healthcare being pulled into that, whether it's a healthcare provider referring them to child welfare or to reporting a drug screen, they're going to see that is all one institution, and it's really understandable that then your engagement with any institution that causes you or your family harm is going to cause some reticence and impact the opportunity you and your family have for health. And so I think that it's not a silo, and these conversations around racial justice need to happen everywhere in our society, because that is how racism has been embedded into many of our structures and systems is systematically. And so we need to take that systematic approach if we're really trying to address equity across the board.
And Joy, maybe you can pick up a little bit on that notion. And, from the perspective of AHA, I certainly know, and I want you to share a little bit about how you are aiming to make hospitals and health systems be oppression-free. But I suspect you're also thinking about a broader lens to all of this as well.
That's right. And maybe Mark can bring up my slide that really captures how we've been thinking about this at the AHA, because in December of 2019, the Institute for Diversity and Health Equity was awarded a grant from the Robert Wood Johnson Foundation to really support hospitals and health systems to address drivers in health inequity. And so interestingly enough, the first deliverable in that grant was for the AHA to conduct an internal assessment of our own DEI practices to determine whether or not we had the capabilities to lead the field. So the findings from that assessment has led to the development of a DEI task force that will actually launch next week. Again, with the goal of ensuring that the experience of employees at the AHA is much more equitable and there's a much more inclusive work environment. But with the grant dollars, what we've also been able to do is to develop what you're looking at, which is an equity roadmap. And it will be our big deliverable this year to really advance and challenge our members. They are chomping at the bit for tactics and strategies to do more in this space. And so we're thinking through, how do you address structural oppression? How do you address structural racism? All the structural isms, right? Ableism, whether it's, you talked about workforce, and maybe it's women in the workforce and some gender issues there around equal pay or lack thereof. And so this roadmap is really our guide to chart that course, because I will tell you that our members are in very different places in this work. So we've got some really leading edge organizations that are, really doing strong work. Our Equity of Care Award winners, for example, this year is Atrium Health. You have the middle of the pack, and then you have those who will have to kind of bring along. And so the way this framework is set up, it's a transformation model. And it is designed to provide those key performance indicators and activities, again, and deliverables along this journey. And so When we look at our leading edge health equity strategies, they cut across these 6 levers that you see on this slide. Equitable and inclusive organizational practices, systematic and shared accountability, engaged communities. Nathan talked about the fact that you don't just parachute into a community and tell them what their needs are. And there has to be this element of balancing the power and ensuring that they're also at the table co-designing those health equity solutions. We want to make sure that there's diverse representation in the leadership ranks inside our healthcare organizations and at the board level. Data. I mean, I don't know how you begin to address healthcare disparities if you don't, look at your data. You've got to segment it. You have to revisit it frequently. You have to put a plan in place to close those gaps. Certainly not least, we know that the care has to be it has to be rendered in a way that's culturally humble, right? You're looking at not just the patient in front of you, but their broader context, the other places they interact with, their broader ecosystem, if you will. And so we recognize that really launching into this work, we've got to first have our hospital and health systems leaders create that goal to want to transform their system into being free of all of these isms. Mm-hmm. And that's really the task that's laid out for us at the AHA.
Right. Well, this is such an important topic. I believe we have questions already coming in. And so I'd love to see
if I may, there's, I think, one piece just I wanted to build off of what Joy and kind of provide maybe a little personal reflection on my path, because, you kind of said, many folks may not be where we're at, but I wasn't where I was at even 5 years ago. Right. And, for me, real turning point was Philando Castile's murder here, a mile away from where I actually asked my father-in-law for my wife's permission to marry my wife. And it really drove home. I was aware and working on social determinants of health, and particularly, early literacy was one of the areas I was really worked on closing gaps. But, it forced me to take a step back and think about, instead of just talking about what law enforcement needs to do to improve the health, what do we need to do in medicine? And what, as a physician, what levers do I have to really help move the needle around addressing structural racism, and realizing that even though the deaths and damage to our Black communities and our other communities of color aren't as visible, they're just as impactful, right? Decisions and the systems that our healthcare has set up around structural racism lead to the same types of death and pain that we see more viscerally when a police officer kills an innocent individual of our community. And so I think that piece of self-reflection, and then what can you do in your space, is really crucial, because we often jump to wanting to say, well, what can I do to research this problem and try to fix it, right? And through that lens, instead of saying, well, how is what the process I'm involved in, the levers that I have, whether it's personal and thinking about things like community organization or even political organization, like Lisa touched upon, whether it's the health systems that we work in, whether it's the physician organizations or professional organizations we are part of, and whether it's engaging with our state and local legislators. There's a lot of different ways that we can start this work. And so I really want to, amplify that. And I love that Joy kind of gives that example of what an organization doing, looking internally first before trying to go out and solve the problem by telling other people what to do.
And before I turn to the couple of questions that I can see here on my screen, because they're terrific, Lisa, maybe just chime in a little bit on that part of the conversation.
Sure, yeah. I was just going to say, I couldn't agree more. And the way I like to think about this, in terms of health systems role, or any other organization per se that wants to address health equity, is to think of it in terms of relationship centeredness and structural competency. So when we think about relationship centeredness, we think about things like self-awareness, like how much are we contributing to this problem? How much are we bringing in our own biases and our own biased behaviors? How well do we know our patients and the people we serve, or our community partners? How well do we know our colleagues who are from diverse backgrounds? How participatory are we in the way we communicate with people, and how respectful are we of them and their values? Do we understand what their values are and know more about how our values may be shared? Or do we have concordance is one of the ways I look at that. And then the more structural piece is this piece about knowing about the structural injustices and the historical factors, and knowing who our partners are and where they're located, and being transparent, about what our mission is, what our priorities are, making sure we have funding and resources allocated to this work. That's a huge thing because, without the resources allocated to it, as we know, nothing often happens. And then are we using those resources to actually put policies and practices into place within our organizations, and including diverse people in our leadership and our governance, as well as among the people we serve and the people who work for us? So I like to think about it in those two big buckets. And I think that as, healthcare organizations and professionals, we ought to be thinking about what we're doing ourselves, and then how we fit into the bigger picture, and how strong of a partner are we? Because clearly no one person is going to solve this entire problem.
That's certain. This is a question from Daryl Gaskin, and I'm going to see who on the panel might like to start with this. It's really interesting picking up on an article, a column today in the Washington Post, my alma mater, and Daryl asks, can you talk about white fragility and how it hinders our ability to address health inequity? Thoughts?
So, well, I'll jump in, and then, so I guess what I'll say is that one of the issues that I think has hindered our progress in this area is, honestly, people have a fear of facing the issue, right? There's a lot of fear around it. There's defensiveness around it. And I think people of all backgrounds need to be mindful of that. I think that, white fragility is one term, and that may be one that actually, I think we have to be careful about the terminology we use, because it does produce certain reactions from people. So I know the term white privilege, for example, conjures up a lot of sort of negative feelings for a lot of people. White fragility may do the same thing. So I think we have to be careful about how we label these things. I think what we're trying to get to is a place of authenticity, and a place where people can feel safe to talk about what their fears and concerns are. People of color want an acknowledgement of what's happened historically and what continues to happen. They want that to be recognized. People who are not of color also don't want to be made to feel guilty, or to feel that they are responsible for things that have happened before they even came to be. But, at the same time, it is part of their responsibility to become aware of things that they might have benefited from, systems they might have benefited from, and how they might have perpetuated or contributed to this problem. So I think we have to be careful. I think all these things are impeding our progress. And I think the more we can give each other grace and space and listen to each other, the more likely it will be that we will make progress. We've got to build these relationships, and we're not going to do that by either staying entrenched in our corners or by attacking one another.
Very, very well said.
I don't know if I can say it any better, but I would like to add maybe a couple of things. One clear example, if you're reading the Washington Post or any publication, is the conversation around critical race theory, and the kind of pushback on even just interrogating the role racism has played in the foundation and structuring of our country and the society, the institutions within it. And so I think that's an example of folks having discomfort with kind of facing those realities, and then having honest conversations about how to address them. And I think a component of the white fragility, which I also agree with Lisa, the terminology is important, and so the something that I've heard, I think that's a little bit maybe better apropos, particularly now that we're a year past George Floyd's murder, and lots of institutions making all these declarations about commitment to racial justice, yet we're not quite seeing the results of that is what's been called white fatigue as well. And that is that there's a pattern that you can see over time of there being an injustice unveiled, people being abhorred by it, committing to change, but then over time realizing that like Lisa was talking a little bit about before, this is not something that's going to happen quickly, right? It's not going to happen in one budget cycle, one election cycle. It's not going to, these are changes that have been implemented over hundreds of years. And so will take lots of time to unwind. And that takes, a concerted effort, and that's concerted change. And change is never something that anyone really embraces comfortably all the time. And so I think it's really trying to, again, connect it to our shared values, our shared goals. And I really like Dr. Kamara Jones, in her definition, she talks about how racism saps the strength of the whole society. And so I really have been trying to focus on, this is really work that we need to do for everyone, like Lisa and Joy have said.
Let me pick up though, Joy, on that notion of this is a long game. And there will be, I'm sure, peaks and valleys on this path. And what thoughts do you have about how we have sustained forward progress when it is hard, when it is uncomfortable for many? In some instances, it may be complicated, right? There are lots of dimensions to this. What kind of thoughts do you have around step-by-step continued forward motion?
Yeah, thanks for that, Ceci, because I think when I look at the AHA's vision statement for health equity, well, actually just its vision statement, I don't think it was crafted to be in response to health equity. But it's a vision of a society of healthy communities where all individuals reach their highest potential for health. And to me, that is health equity. So you and I, Ceci, we likely have different needs. We need different supports. And so we're not looking for sameness, right? That would be equality. So I think we'll know that we've achieved health equity when the quality of the care that we've been talking about doesn't vary based on personal characteristics, race or gender or geography, or socioeconomic status. And so the work really involves removing those barriers that are structural in nature that maintain that system of advantage and privilege that I was talking about. And that is uncomfortable. And so how do we get folks to get comfortable with being uncomfortable? Unfortunately, I don't think this is something that any one of us can solve by ourselves. We didn't arrive here by ourselves. And so we need that community approach. We need our allies. We need everyone on board in order to really move the needle in this work. But if you don't dismantle the structures and the systems that have maintained this, structural racism to me is a brand of structural inequality, right? So you have opportunities and rewards and resources that are being distributed along a hierarchy in society. And those systems have been in place, and the rewards, how you distribute your rewards, I mean, it's based on policies and history and law. And so there's this history where we've assigned inferior and superior placement along that hierarchy. So we have to dismantle those structures, and I think identifying and really addressing the root causes of the inequities and the structural nature of this work is where we have to begin. But it's an all hands on deck approach. I mean, I don't think any of us can sit idly by. I think someone was asking earlier, or maybe it was in our conversation about, health equity is a broad term. And so do we dilute the effectiveness if we don't all coalesce around this one definition? And there is no silver bullet. There's no single solution to advancing health equity. And so I think it's important for organizations to define and articulate what they mean when they're talking about health equity, how they then develop a plan to pursue and advance health equity. And as long as folks inside of an organization are able to, again, coalesce around a strategy and the tactics and the actions to move the needle in service of equitable outcomes, I think we're directionally correct. And it's really going to take all of us kind of going in the same direction.
A question here with plenty of votes from the audience sent in from Denise Doherty. And it is, and Lisa, maybe I can ask you to start and then Nathan on this. Is there anything health system can do in regard to, in quotes, social determinants beyond screening and referring to services? I sure think from the perspective of our community health plans, the short answer is yes. But let me have Lisa elaborate on that.
Sure. I mean, I think probably many people at the conference are aware of the fact that the National Academies of Sciences, Engineering, and Medicine actually did a report last year, or maybe it was 2 years ago now because of the pandemic. I've sort of lost a year here, on integrating social needs into the delivery of healthcare, which was basically moving care upstream. And one of the things they talked about is awareness of people's social needs is just the first step. And, making referrals is maybe, helping people, assisting them. But we had the 5 A's that was part of that report. So awareness and assistance were 2 of the A's, but there was also adjustment. So we can adjust the way we deliver care by being more flexible in where and how and when we deliver care. We can better align our care with the needs so we can basically partner with others in the community and invest in some of their programs. And then we can also advocate. So that means that we don't just focus on what we're doing, but we also work with policymakers and advocate for better social resources for community well-being. So that's what we can do. Not every organization is ready to do all of that, but I would say awareness is the first step, because if you don't know what people's needs are, there's definitely no way you're going to be able to address them.
And now I would just chime in that with so much data at our fingertips, you really can get at many of those fundamental drivers that you're talking about. I mean, I will share from the perspective of a community health plan, they can now really identify and zero in on specific needs in specific populations and communities, and then be very smart about the targeted outreach and intervention. And Nathan, that's why I wanted to turn to you on this, because I think, please correct me if I'm wrong, that the COVID experience, and especially now with the vaccination campaigns, there's much to learn right now on this question.
Yeah, and so I think the COVID experience, and what I'm guessing you're getting at, is still in that kind of line of like service delivery, and how can we address social determinants through service delivery. And so you're thinking about, well, what are we really focusing on that's decreasing barriers and access? Well, why don't we decrease these barriers and access to all care, not just for COVID-19 vaccination? And I think a lot of some of the issues we see, even with being able to reach communities that have been hit hardest, like our BIPOC communities, is that there hasn't been that honest and continued sustained presence in community to try to help get them access to resources. And so now it's like, oh, now you are interested in our health and welfare when it impacts you and the economy and everyone else. Now you're coming in here and you want something from us. And so I think what I'm really trying to push for is, what are the investments we made in the infrastructure we've built up around outreach and engagement with community, as well as how we are bringing them the vaccine, that we continue. And so that when the next pandemic comes through, it's not just, oh, you're here just now. You've actually been here every time every spring you come around with a mobile vax unit and you're helping get our kids caught up in their immunizations, for example. But I think there's another piece I really want to get to with this question that kind of, again, goes to that internal reflection and what can, health systems be doing to address social determinants of health within their own employees. Like, in Minnesota, health employers, health systems, employ about 5% of the employees. But you look across the board and there's not paid family medical leave, for example, for employees. That is a social driver of health. And if they made the commitment to that, they could help lead other employers to do that. There's other big employers that are doing that. And it would directly impact many of their not only own employees, but those employees are their community members. And oftentimes they're taking care of their employees in their hospitals as well. And so thinking about fair wage and how do we make sure that folks have a livable wage in the systems that we actually have control over. And then, also there are other kind of straight up interventions. I come from early literacy, so reach out and read and being able to really get early literacy into the clinics and being able to help families with those sorts of tools. There's lots of other early childhood interventions that we could really be investing in to address these gaps earlier. And then I really do like that piece about advocacy and how many of these large health systems have very active government affairs staff and who are there talking and protecting their interests, but they should also be looking at the interests of the communities that they serve and how does transportation policy, housing policy, childcare policy, educational policy impact the communities, and whether maybe they have to give a little up from their bottom line, but that's an investment in the long run to the health of their communities.
Nathan read my mind, and I'm going to ask our panelists now that we have kind of a stack of questions. We might go a little bit quickly here because I want to get to so many of these. And just following on Nathan's point about advocacy, Joy, one or two policy strategies that you think would start to really make some progress in this area?
So I think we absolutely need to incentivize folks to do the right thing, right? So the system is designed to deliver the results we're seeing. And we've heard that saying, Don Berwick and others, but at the macro level, we need to ensure that there are those financial incentives for reducing health disparities, not only through care delivery, but also through payment model enhancements and reforms. And so I'd say that that's an imperative to really engage in this work. I think the moral argument we have really good traction around that. The business, where we need to kind of pivot is to, and I don't want to say it's ensuring efficiencies on the operation side. So equity in all things approach, right? So this work of equity is not just siloed and resting on the shoulders of that one executive inside our hospitals and health systems that has diversity in their job title, but it's really thinking through how do you get that leadership commitment from the very top, and then how do you cascade that accountability throughout the organization to ensure that, as Nathan said, from wherever you sit, you recognize that there is a role for you to show up. So whether you're on the front lines or leading a team or again, at the executive level, how is it that equity is interwoven throughout all of the decisions that we're making? And so I would challenge our health systems to think about their procurement practices, for example, how to diversify your supply chain, of course, the recruitment and the retention of diverse staff. What do those policies look like? So right now with the infrastructure bill on the Hill, workforce has emerged as the number one issue our members really want us to weigh in on. We held a workforce task force over the course of 12 to 18 months during COVID, by the way. And the one thing that emerged top line was benefit design, rethinking our benefits and designing benefits that workers value. So maybe it's a housing voucher or a transportation voucher. And again, what do those policies look like? And so I think it's the marriage of both the moral imperative, but also the business imperative to do this. Policies are aligned across both.
And
I can give one concrete example.
Sure,
too.
and then I'm going to go to the next one. Nathan, yes.
Yeah, so just a quick concrete example of how we're approaching this in Minnesota Medicaid is looking at our RFPs for our managed care organizations that are serving our children and families. In our most recent round, we specifically ask our organizations applying how they are dealing with structural racism in their systems, but then also what is their expectation of any services that they do subcontract, right? And so we could, because if they say, oh, we're doing all these great work, but then they contract out services to organizations that don't share those same values, that's going to impact our members and our enrollees. And so putting that into the RFP then allows us to talk about it in the contract. And really the overall goal, like Joy is getting at, is to make the system reward people who are making the right decisions.
Yes, absolutely. And Lisa, there is a question here from Teal Benavides. It is, one barrier to equity is the science on racism. Can you discuss the impact that our academic systems have on the discussion of systemic racism in scientific literature? So Teal goes on to note peer reviewers, tenure, other processes that may be inequitable.
Yes, I mean, that's a very important point. And we've definitely, it's been more in the limelight recently with some pressure being put on academic leaders, journal editors, so on and so forth, for how they discuss this issue and how they address it scientifically. So I think a lot of academics are being very vocal about the fact that this racism, persists in academia as well, and in the funding and support for researchers who do this work and for the science of this work. If we're seeing disparities in that, we can understand why we're not getting as much of the science of that out. And we're also seeing biases in the way that science is reviewed. So I think, yes, it's a barrier. I do think a lot of work is being done, and I think it's a matter of getting it, continuing to fund it, but then also using it, and making sure that forums like this one are those in which we can talk about what the evidence base. We know that there's evidence, strong evidence for implicit bias in healthcare and for the benefits of, for example, race concordance in the patient-physician relationship on not only patient experiences, but on health outcomes. So we need to draw upon that evidence base. There are interventions that have been tested, even though they're nascent right now, to reduce the negative influences of implicit bias on patient outcomes and also on sort of performance of other people within the academic and the healthcare environment. So we just need to use that evidence, and we need more leaders, people who are attending this meeting, to do that work and to be the spokespeople for it.
Mm-hmm.
Yeah, another quick one.
Question.
Sorry,
I'm going to go to this.
We could do a whole thing on.
Question.
Oh, I was just going to say we could do a whole thing on race-based medicine, but there was a recent, again, citing Rhea Boyd and Edwin Lindo, who talked about gatekeeping in academic publishing. And the term that Edwin Lindo used that I think really resonates, if you're familiar with redlining for housing, is there's been redlining in our academic journals around even talking about racism and how we're even allowed to talk about that. So we can't solve a problem if we can't talk about it. We can't solve a problem if we can't present solutions that clearly define the issue. And so again, lots of work to do there.
Good point. A question from Bridget Sarika, wondering, when it comes to a more diverse and equitable workforce, what efforts will have the greatest impact? And she specifically goes back to, I think it was Joy mentioning in your opening remarks, the lack of progress when it comes to Black physicians. What immediately popped into my head, Joy, was, is this a medical school issue? Or how do we get at these workforce challenges?
So it is a medical school issue. I mean, if you think way back, when so many of our Black medical schools were forced to close their doors, right? Because they couldn't meet the standards that were put upon them, pretty onerous standards around facilities and the quality of the facilities that they needed to have. And so we saw just so many shutter. And honestly, we haven't recovered from that. There was another study that I should bring forward from most of you are probably familiar with it. I think it was in New England Journal of Medicine. Brown researchers found decades-long decline in Black males, Native Americans, and Alaskan Natives, medical school students. I'm referencing here. There's a decrease, I want to say, from 1978. So not, again, the trend lines are not heading in the right direction. Of Black students, Black medical students, a decrease from 3% in 1978 down to 2 and change in 2019, just 2 years ago. So, and I think during that same time period, we saw a decrease of Native American and Alaskan Native medical students who accounted for less than 1% of medical student bodies. So you get back to concordance that Lisa was referencing earlier. You know, we're just not producing enough Black physicians. And the physicians we are producing, because I don't necessarily believe that we're looking for a 1-to-1 ratio match that Black patients ought to have a Black physician, because that lets our white physicians off the hook in terms of their accountability, ensuring high quality care that's not biased. But when you look at the study that came out of University of Virginia in 2016, where medical students were taught that there were biological differences between Black folks and white folks, right? In terms of the skin, Black people's skin is thicker and our blood coagulates at a faster rate. I mean, that has real implications when you show up for care and the way you're assessed and treated, for example, for pain. And so I think there's just a lot of work that needs to be done to get, you know, if you've got the educators from decades ago who were taught in a certain way, educating our current medical students, I mean, that legacy thinking is just being passed on. And so we've got to interrupt that in some real way.
My friends, I knew that this was going to happen. This is such a rich topic, such a stellar panel, as Lisa said. We are down to 1 minute for each of you for a final question, and I'm going to pose it this way. Some progress is being made, not enough action. I heard from the three of you today. There's so much to be done. Can each of you offer, just in 1 minute, the concrete 1 or 2 things that anyone here on the Zoom with us today could take back to their organization, their community, their family, their local government, you name it, 1 or 2 action steps that they could pursue that will start to make an impact? Lisa, I'm going to turn to you first.
Sure. Well, what I would say is that we each have a role to play in solving this problem. So on an individual level, if you're a person from a disadvantaged community or from a disparity community, you are your best advocate. So you can advocate for yourself. You can learn how to be an empowered patient and advocate for yourself and your family members when interacting in healthcare. When you're in an organization working, you can learn how to speak up and hold your leaders accountable. If you're not from a disadvantaged group, you can be an active upstander and speak on behalf of those who you see being treated unfairly. So that's just on an individual level. But on an organizational level, you can actually work in partnership with other organizations that are addressing these social issues, social determinants. You can look carefully at your practices and policies to see whether you are unintentionally delivering inequitable services to people from disadvantaged communities, and especially along racial and socioeconomic lines. You know, and then I would say you can also encourage policymakers. You can go out and vote, become civically engaged, yes, and support people who support equitable policies.
Okay, sorry for the squeeze here, Nathan.
Yeah, I will quote Dr. Kamara Jones again and say, you know, she says, when you're dealing with structural racism, you have to be able to first name it. And so that means you need to understand how structural racism works. And so both as individuals and institutions, we should first understand how structural racism works, name it, then see it, identify where it's acting in your life, and then act together to actively dismantle it. And so those are all steps that individuals can take, and those are steps that organizations can take as well.
Wonderful, thank you. And Joy, final thought.
Yeah. Thanks, Ceci. I think we're tinkering around the edges if we don't take on the work of identifying and addressing the root causes of inequities and structural barriers to achieving health. And so I would just encourage us to think about those communities that we're there to serve. So establishing community partnerships, we're being really intentional about bringing in those folks who have been on the fringes of society, who've been structurally marginalized, and bringing them into the conversation in meaningful ways.
That is terrific. Just as the red flashing sign comes on, I want to thank these panelists. I learned a great deal in this conversation. Thank you, Academy Health. What a great session. I think, Lisa, you're back.
Great. Wow. Thank you. What a great discussion. And thank you, Ceci, Nathan, Joy. It was really, and Lisa. Sorry, I always forget. Lisa, every time I hear that name. And clearly we are just scratching the surface of what we need to consider and take forward, and the work ahead of us as a health services research community, passionate about making healthcare better for all. So we didn't get to a lot of the questions that folks had asked in the chat, but there is one of the Continue the Conversation sessions right now, starting with Reed Tuckson, who is also a masterful moderator. So please join us there. And don't forget to check out the channel chats and answer the question of the day and do all kinds of other things. So thank you, Ceci, and great panelists.
Thank you.
Thank you.